Congratulations once again to all the stakeholders in this important life milestone for the dissemination of this important research that is homegrown within Pakistan, as Pakistan was one of the countries that was part of this trial. Back to your question to say how often should we revise our guidelines and what is required. So as a country office, of course, we support the government to translate or to contextualize the guidelines that have come from global level and ensure that they are operational at country level. This we do hand in hand with government as well as local experts within the country and partners like UN agencies and other partners. The frequency is not prescribed because we don't, the level of evidence that is available cannot be prescribed. So as soon as evidence is available and WHO is able to release global guidance, then we run around with the host government to disseminate the guidelines and discuss with the government to translate the guidelines and contextualize the guidelines. I must be quick to say here that it's upon the government to agree or to disagree with the available guidelines. There have been contexts, probably not in child health, but in HIV, where governments have decided to do otherwise, contrary to the global guidance. At times, global guidance from WHO is late, and countries can decide to move ahead with the homegrown evidence or reasons that are best applicable to their context. I'll highlight an example of the introduction of HIV treatment for life for mothers who are found HIV positive, in which countries in sub-Saharan Africa decided to put women on treatment for life before WHO had decided to do that. They had reasons in terms of fertility. They couldn't afford to start and stop treatment, and logistical issues, frequency of pregnancies that women would present with, and such decisions are made. But at country level, all we do is to facilitate what is available and find out the appetite of the host government to operationalize the global guidance. And we are happy that so far the Pakistan government has been receptive to most of the guidelines that have come from WHO. Challenges could be there, as highlighted by the previous speaker, when it comes to provincial governments and the implementation or operationalization. But in general, WHO guidelines are respected and they are accepted by government. For us to move forward with the current guidelines or the current evidence that has been generated by this research, a number of operational readiness should be there at different levels of health service delivery, be it primary healthcare level, secondary healthcare level, as well as tertiary healthcare level. We need to build capacity of our lady health visitors, community health workers, as well as train all people that are in contact with children to be able to identify as outpatients the signs of PSBI and provide the required treatment. But at the same time, as it has already been mentioned, treatment should be available. Stocks should be available in the health facilities, both amoxicillin as well as gentamicin, and also a strong referral system with clear protocols that the primary health care level can follow and refer when necessary. The secondary level should also be able to coach or mentor the primary healthcare level. There should be supervisory visits so that the primary healthcare level service providers are handheld when implementing the guidance that has just come out. The tertiary levels have also a critical role to play, as they are also responsible to provide clinical oversight and also provide mentorship as well as feedback to both the secondary and primary healthcare level, as well as monitor antibiotic resistance trends. The issue of AMR has already been highlighted earlier on in the discussion. So that is also an important aspect.